So today's topic is acute kidney injury and renal replacement therapy in the critical care setting. So just briefly about acute kidney injury. It has a significant association with high mortality in critical ill patients. Uh, I do remember Dr. Grover saying once that the moment the patient is on filter, basically the mortality rate increases by 50%. So it's always a it's all on us basically when we have to start the patient on filter, when not, and it's really a crucial step in the patient's care. Renal replacement therapy provides supportive management for patients with severe AKI and patients who have multi-organ failure. So when do you say the patient has acute kidney injury? If there is a rise in the serum creatinine, which of 26 micromole per liter or greater within 48 hours, or there is a 50% or greater rise in the serum creatinine, known or presumed to have occurred within the past 7 days. If there is a fall in the urine output to less than 0.5 ml per kilogram per hour for more than 6 hours in adults and for more than 8 hours in children and people. So you should just keep in mind, it's basically not like a decreased urine output in just 1 or 2 hours. You just have to monitor. You have to see the ITU chart, basically, if the patient has been oliguric or the amount of urine which the patient is producing is less over a period of 6 hours if the patient is adult. And then only you can say, okay, the patient's kidney might not be working very well. And then you can just escalate it and see what can be done. The other definition that comes is from the GFR, which is a 25% or greater fall in eGFR in children and young people within the past 7 days. So there could be a number of causes of AKI. It could be pre-renal, it could be renal, it could be post-renal. So if you talk about the pre-renal causes, there are like lots of medications because of the vasoconstriction effects, like ARBs and ACE inhibitors and NSAIDs. That's the reason we make sure when the patient has acute kidney injury, we make sure that all the nephrotoxic drugs we have stopped so that the renal function doesn't get worsened. In addition to that, like there's a cardiorenal syndrome and like hepatorenal syndrome, the patients of liver failure, when it gets further worse and then automatically the kidney gets involved, and that's what we call as the hepatorenal syndrome. The other causes are like the volume depletion, which is again an extrarenal cause, like severe vomiting, diarrhea, or maybe a burn case. There could be some renal causes if we use lots of diuretics. It could be an overuse of diuretics, or it could be osmotic diuresis. Systemic vasodilation, which could be sepsis, and it could be a neurogenic shock. If I talk about the renal causes, there could be glomerulonephritis that could be related to hypertension, could be diabetes mellitus, could be a vasculitis, and could be a lupus, and maybe a post-infection. Interstitial nephritis, again, there are lots of medications like antibiotics such as penicillin analogs, and could be cephalosporins, could be rifampicin, could be interferons. There are some viruses that can lead to interstitial nephritis like HIV, CMV, and Epstein-Barr virus. It could be bacterial like Legionella. It could be fungus, which could be like candidiasis or histoplasmosis, and it could be systemic like sarcoidosis. The other renal cause is the tubular nephritis. It could be the ischemia from the prolonged hypotension, and could be exogenous toxins like aminoglycosides, methotrexate and cisplatin, or it could be endogenous toxins like rhabdomyolysis or maybe tumor lysis syndrome. The vascular causes is a renal atherosclerotic disease, or it could be a malignant hypertension or renal vein thrombosis. If I talk about the post-renal causes, mostly the obstruction and such as stones, and it could be crystals, it could be tumors, it could be clots. If I talk about the extrarenal causes, it could be hypertrophic prostate or maybe cervical or prostate cancer. So The obstruction seems to be the most common cause. What I remember from A&E is when a patient comes to us and if it seems to be a ureteric stone and if the size of the stone is very small, it doesn't bother us. We still send the patient home. What we are concerned about when we look into the patient's renal function, if the patient's creatinine and urea has gone dramatically up. So in that case, we have to immediately refer the patient to urology, and because of course the obstruction is leading to AKI. So that's one of the commonest reasons, the post-renal causes of AKI. Moving further, so this is the KDIGO definition about acute kidney injury. So it's just the other way of saying, so if the creatinine is 1.5 to 1.9 times the baseline, or the urine output is less than 0.5 ml per kilogram per hour for 6 to 12 hours. For stage 2, if the creatinine is 2.9 times the baseline, and the urine output is less than 0.5 ml per kilogram per hour for more than 12 hours. For stage 3, if the creatinine is more than 3 times the baseline, or maybe the urine output is less than 0.3 ml per kilogram per hour for more than 24 hours, or the patient remains anuric for more than 12 hours. It's basically one of the important criteria, because what happens if the patient comes to A&E and if the patient is maybe it's a new fresh AKI, if it's a new AKI or something and you really want to refer the patient to medics, so basically they look into all these criteria. Basically, if the creatinine has gone, or if the patient is known to have AKI and then CKD, and then if the kidney function has really got to worsen. So this criteria basically applies at all those places, and this can be clearly seen in our guidelines as well. So coming to the conventional indications for the renal replacement therapy. So the first and the foremost is a fluid overload, and which is like when someone is resistant to diuretic therapy. When someone is in metabolic acidosis with a pH less than 7.15, refractory to medical management. It could be hyperkalemia where the potassium is more than 6.5, refractory to medical management. It could be some uremic symptoms or signs like encephalopathy, pericarditis, and bleeding diathesis. Some other important indications for RRT is the poisoning with a dialyzable drug or toxins. It could be hypothermia, which is refractory to regular cooling techniques. It could be a life-threatening electrolyte derangements in the setting of acute kidney injury, or maybe progressive azotemia or oliguria unresponsive to medical management. So coming to the timing of RRT, so there's one way, basically what we usually do on the floor. It's called as the furosemide stress test. It's used in the euvolemic patients with acute tubular necrosis and no underlying CKD, where we give a bolus of furosemide, maybe 1 to 1.5 milligram per kilogram. But if they produce less than 200 mils of urine output over 2 hours, that basically reflects that there is an increased risk for the progression of AKI, and then the patient might need a RRT in that case. The other way is a delayed strategy, where waiting for 48 to 72 hours after progressing to AKI, or until an absolute indication arises, such as in case of septic shock. There may be potential benefits in initiating RRT even before the absolute indications. That could be in some cases such as severe burn, in post-operative patients, particularly after cardiac surgery. So coming to the modalities of RRT. So in our ITU, we do use CRRT, which is basically CVV-HDF. So it's a continuous renal replacement therapy. And what we use is a continuous veno-venous hemofiltration. Intermittent dialysis happens in room B, but the patients who needs dialysis on alternate basis. And the other one is the SLED, which is sustained low efficiency dialysis. So again, we don't use SLED in our ITU because it's just one form of IHD equipment that's used to filter the patient. with using like a very small amount of dialysate, and the blood flow rate is kept on the lower side. What we use in our what we use in ITU other than CBVHTF is SCUF, which is basically a slow continuous ultrafiltration. The purpose of SCUF is basically just to removal of fluids, but it does not allow significant solute clearance. So coming to just to see the differences. So intermittent dialysis basically removes the lowest weight molecules. SLED, I won't focus much because we don't use it here in ITU. But anyways, it can filter these small and middleweight molecules. CRRT, the CBVHDF, what we use here in ITU removes the small and middleweight molecules. So if you look into the CBVHDF filter, you can clearly see on the screen that what is the blood flow. So normally the nurses, they put the blood flow around 200 ml per minute for our CBVHDF. For intermittent dialysis, the blood flow is quite high. It's basically 300, 400. That's the reason you complete the dialysis in just 4 hours. But the continuous renal replacement therapy, we just keep the flow as 200, and we can continue for 24 hours, even more than that. So the dialysate flow is always high in case of intermittent dialysis, which is 500 mL per minute. But if you look into the CBVHDF, you can clearly see something in green color written as dialysate, and you can see it's 1 liter per hour. Duration, I already spoke about. Hemodynamic stability our CBVHDF is very compatible. We tend to use even in those patients who are hemodynamically unstable. But intermittent dialysis is not suitable for unstable patient. That's the reason when our patient gets more stable and they need intermittent dialysis, we step down the patient and they can come back for intermittent dialysis on alternate basis. Intracranial pressure. So intermittent dialysis basically increases. I really don't know how. I have to work on it. But CBVHDF does says like there's no change. Regarding anticoagulation, that's the most important thing. And what I assume that's the main thing when as a SHO, when someone is new, they struggle, especially overnight, basically, if the consultant hasn't specified for some reason or someone has forgotten to say basically what anticoagulation to use. So it's really important in ITU, basically what to be used and when to be used. So I have few slides on it and I'll just go through it. Before that, just comparison. The concentration of the renally cleared drugs there is a major fluctuation with ISD, but CBVHDF, there's a least fluctuation. The cost is definitely high for our CBVHDF. For intermittent dialysis, you can do through AV fistula, you can do through tunneled or non-tunnel catheter. But for CBVHDF, we need either a VAS cath or we need a Tessio line. It's more compatible with the intermittent dialysis, but CBVHDF is not compatible. The urea clearance is a bit high with intermittent dialysis, which is 150 ml per minute. And with CRRT is 30 ml per minute. So this is what I have noticed, like even if the patient remains on filter for 12 hours, 14 hours, you can see the urea comes down very slowly. And so it could be, that clearly explains from this chart. Anticoagulation, like the way I said, CBVHDF does need anticoagulation, but intermittent dialysis doesn't. So if the filter clots in CBVHDF, we lose around 150 ml of blood. It's really a very important thing. At the end of my presentation, I will just tell you, basically what need to be taken into consideration so that we can avoid losing these bloods, especially in those patients who are into multi-organ failure and those who are hemodynamically unstable. Coming to this dialysis disequilibrium syndrome, it's more common with intermittent dialysis, but not with our CBVHDF. If the patient has any toxicology or anything, there's more risk of rebound, but it is less with CVV-HDF. So if you look into intermittent dialysis, you just need a normal tap water or maybe a hygienic effluent. But for our CVV-HDF, we need lots of dialysate bags. You can see the under the filter, those Prismasol, Prismacol, and Prismicitrate, all those things are being used, especially because the commonest used anticoagulant for CVV-HDF is citrate, provided the patient is not, there's no contraindication, like if the patient has liver failure, we don't use it. And the risk of bleeding with citrate as an anticoagulant is very, very less. Moving further. So the pros and cons of different modalities of RRT, just brief again, so that we have a clear picture how CVV-HDF is more superior, especially in ITU compared to other modes of dialysis. So intermittent dialysis, of course, like the way I said, it's a short duration. It gets completed in 4 or 5 hours. You don't require anticoagulation, or you require a very little anticoagulation. And the potassium, it regulates very well, and it's not like a tedious task. If I talk about CVV-HDF, there is less chance of hemodynamic instability. It's easy to operate, and there's a better solute and volume control. The disadvantages of intermittent dialysis. So it's a bit technically difficult, and of course requires a fresh water supply, can cause hemodynamic instability. And like the way I said, there's a more chance of dialysis disequilibrium syndrome, which can lead to cerebral edema. But CVV-HDF does require anticoagulation. So the anticoagulation which we use in our ITU is citrate, or we use heparin, or we use Flolan, which is basically epoprostenol. CVV-HDF does cause hypothermia sometimes. That's the reason sometimes you must have noticed when you go bedside, some of the patients, they are on bare hugger while they're on filter. I didn't know that before, but of course, after going through all my presentations, maybe I realized that could be one of the reasons why patients go hypothermic, because that could be one of the disadvantages of CVV-HDF. Moving further, so the choices. So like the way I said, or the intermittent dialysis is considered to be the first line therapy. If you need a rapid correction of electrolytes, you need urgent fluid removal, or in case of any poisoning. But CRRT, so our CVV-HDF, just to repeat, is one form of CRRT. Is associated with smaller increase in intracranial pressure, and it is a preferred option in liver failure awaiting transplantation, in some brain injury patients, because of course you don't want the intracerebral pressure or intracranial pressure to increase and leading or predisposing to cerebral edema. Patients with AKI associated with hypercatabolic states, such as burn and rhabdomyolysis or tumor lysis syndrome, may benefit from CVV-HDF, as these conditions causes more hemodynamic instability, metabolic acidosis, and fluid overload. So RRT and organ support. So in the intensive care setting, AKI occurs in high percentage of patients with ARDS, or maybe the patient has gone into cardiogenic shock, or maybe fulminant hepatic failure. So if I talk about the RRT in heart failure, so the Unload trial, it compares basically the safety and efficacy of early ultrafiltration versus the standard diuretic therapy in patients presenting with decompensated heart failure. So based on this trial, if there is early ultrafiltration produced greater fluid and weight loss at 48 hours with reduced rehospitalization, number of hospital days, and unscheduled clinic visit. But the serum creatinine was nearly similar in both the groups. In light of the above results, we broadly agree. So if you look from the recommendations of the American College of Cardiology, it says that the ultrafiltration is a reasonable therapeutic modality in refractory heart failure, not responding to medical management. So if you talk about the liver failure, so what happens, like the way I said before, if the patient has liver failure, they go into hepatorenal syndrome. But CVV-HDF is actually helpful if there's a patient is basically due for liver transplantation. Otherwise, there's no evidence that says that RRT basically can increase the survival of the patient in those who has hepatorenal syndrome. RRT in acute respiratory distress syndrome. So basically, ARDS is seen in up to 15% of the ICU admissions, with sepsis being the most common cause. The FACT trial demonstrated that a conservative fluid management strategy was associated with a reduction in mechanical ventilation and RRT requirements. So anticoagulation in RRT. So anticoagulation-free renal replacement therapy should be considered only in those patients who has high risk of bleeding or who have severe thrombocytopenia, they have severe coagulation disorder or liver function, or if there is any contraindication to the regional anticoagulation like citrate. So the most important thing is if the patient comes to ITU and the patient is known to have atrial fibrillation or the patient has DVT and you can see that the patient is already on therapeutic anticoagulation. In that case, if the patient is on, in that case, basically, you don't have to prescribe any anticoagulation separately. So the patient will continue on his systemic anticoagulation and then you will just continue on filter. So regional anticoagulation, the regional citrate anticoagulation basically consists of citrate infusion. So to the blood before the filter of the extracorporeal circuit, thereby chelating ionized calcium, a key cofactor of many steps of clotting cascade. So basically what happens, so most commonly used is a citrate filter, right? So what happens, the citrate circuit basically takes away your calcium. So if the blood that's returning back to the patient's body is depleted of calcium, that's the reason if you look over this CVVHTF filter, you can see a calcium chloride infusion attached literally at the end of the circuit is attached where it goes to the patients directly. So basically whatever blood is returning that gets in touch with the calcium so that our calcium remains the same in our body, and because it's really an important thing for our important step of our clotting cascade. So what the nurses do basically, they check our arterial blood to see the calcium level, and at the same time they take the calcium level that's from the blood that's returning, so they get to know basically how much calcium has to be replaced. So they have their own protocols and they follow it. So this technique basically allows prolonged hemofilter life without systemic anticoagulation. It can be utilized in patients with moderate to high risk of bleeding, like the way I said before. There are other options like heparin anticoagulation. So regional anticoagulation, like the way I said before, is the preferred modality. And of course, there is evidence that the bleeding rate is a bit low and the hemofilter survival is a bit longer. Systemic anticoagulation, I already told about it. So it's basically the unfractionated heparin infusion remains the most widely used, despite being a second line option. And available evidence suggests that RCA regional citrate anticoagulation is superior in hemofilter survival and bleeding risk. If there is any, if we have to use antidote and if you're using heparin, then we have in hand protamine sulfate, which we can use. If you use heparin for maybe over a period of 5 to 10 days, then the chance of having heparin-induced thrombocytopenia is always there. And that's when we get in touch with the hematologist and we set all the hit screen and all just to see if the patient has got this heparin-induced thrombocytopenia. Our aim is to maintain the APTT between 40 and 45 seconds, or we can say APTTR, which is between 2 to 2.5. So conclusion of what I have said so far, the role of renal replacement therapy in ICU is primarily to support the renal dysfunction with multi-organ failure. The optimal time to commence the RRT remains a topic of literature debate. Surgical patients may benefit from early initiation, while septic patients with multi-organ failure may benefit from a delayed strategy. Continuous renal replacement therapy is considered the first line when managing critically ill patients with hemodynamic instability, although there is no definite evidence that suggests mortality benefits or renal function preservation when compared to IHT. Renal replacement therapy is a potential therapeutic option when managing resistant congestive heart failure. However, other therapies like hemoperfusion in sepsis have proven ineffective. Regional anticoagulation has comparatively lower bleeding risk compared to heparin-based therapy and remains the choice of anticoagulation in CRRT. In our ITU, we do have ipoprostenol as an option as well. So if you can't use citrate, and if you still want to use anticoagulation, but you know the risk of bleeding is high, then you can use ipoprostenol over heparin, because the risk of bleeding with ipoprostenol, which is also called as Flolan, is less compared to heparin. At the end, I just want to just say a basic thing about the CVV-HTF filter. Uh, so especially for the SHOs, you know, when you go for the bedside assessment and you can see the patient is on CVV-HTF and the filter is running. So sometimes, not sometimes, almost like the nurses gets concerned when the transmembrane pressure, you can see from the screen that what's the transmembrane pressure? It's written as TMP. So if that transmembrane pressure goes more than 200, it's basically an alarming sign the filter might get clotted. So if you know that the patient is already on filter for more than 12 hours or maybe 14 hours, and you know that if you stop the filter at this point, it might not affect the patient. So you can take a decision rather than the filter gets clotted and you are not able to return the blood. Like the way I showed in my previous slide, we lose around 150 to 160 mils of blood. So our filter is very smart. It basically tells you that the filter is about to clot, but not every time. Sometimes it just gets clotted and you're not able to return the blood. So especially those patients who have like sickle cell disease patients, or maybe any patients with multi-organ failure, where like you can save where the chance of dropping hemoglobin is a bit more. So you can just save it in those things. The other important thing, if you look over the filter at the extreme bottom, you can see something written as access. So if the access value is too negative, what I mean by too negative is like if it is -10, -12 is fine. Sometimes the access value goes up to -200. So basically what that tells is that CVV-HTF, the VASCAT, so basically it takes the blood from the venous circuit and brings the blood back into the venous system. So the filter is having trouble to take the blood out from our body into the machine. So because of that, the access gets very negative. That means something is wrong with the VASCAT. Maybe we have to reposition it. So it's just small tips basically that might be helpful for especially SHOs when you go bedside for the assessment. And the standard effluent, which is set for most of the patient, is 35 mils per kilogram per hour, and based on the patient's body weight. You can clearly see what's the fluid removal, and if you click on it, you can see how much fluid has been removed in last 12 hours or 24 hours. So that's all from my side. Thank you so much. Any questions?